So the first thing I want to say is, if you're looking ahead at the slide deck, the handouts, don't worry, we're not doing all of that biochemistry stuff. And the reason, and I really called that down, I stole this from my friend Lorna Scoggins. She and I worked together forever, and she's teaching now, and she's a really good teacher. And so she heard I was doing this, and she said, here, I've got this. So some of this is like nursing student type stuff, but not all together. I sneaked some other stuff in and took a lot of it out. So, and also I made this list. The original request I got was that you all were interested to know what meds are used for what conditions. And so that's what this list is. And you'll see that I cleverly color-coded it. Yellow for anxiety, right? Caution. Blue for depression. But anyway, I ran out of good colors, so that we just kind of stuck with that. Thank you for printing those in color too, by the way. But I think as I was doing this, it kind of helped this list. It kind of helped shape how I envisioned this talk to go, which is that in years past, in decades past, and well, I've passed through a lot of them as a psychiatric nurse, we used to use this drug for this, and this drug for that, this, and this drug for this. And it wasn't, and what's happened over time as there's been more and more research into brain function and chemistry and the way these illnesses present, is that we have to quit thinking about treating the disorder. We have to quit thinking about treating schizophrenia, and we have to start thinking about what's actually happening in the brain. So you see, when you look through that list, you'll see a lot of overlap. A lot of drugs are used for the same disorders, and a lot of disorders have a lot of different drugs. So just bear that in mind. That's really been a great thing, I think, in terms of how we treat people, both kind of in reality and then kind of symbolically too, is that we're really looking at what are their primary symptoms. So this is for you to keep, and if you find any mistakes, you can let me know, because I'm sure that there are some. So what I did was listed in the second column, those are the generic names, and then in the third column, that also known as column, those are the brand names, and some of these have more than one brand name that I didn't put on there. And then the class of drugs, that in the books, the class of drugs that those particular drugs fall into. So I don't have my clicker. So you guys can thank Lorna. Which button do I push? This one?
Yep, you got it.
Y'all can thank Lorna. I wish she were here doing this. There we go. So I did want to say just a couple of words about this, because it really is kind of at the heart in a way of why different drugs can be used for different conditions, because they're treating kind of the same things. So, and you all know that these chemicals in our brains called neurotransmitters, right? And those are what send, for better or worse, they send messages from nerve cell to nerve cell. And they have to be made and put into action. And as I was doing this, I thought of this great analogy, so bear with me if you will, because it's kind of silly. But if you live in my house where your husband is a complete cookie fiend, and I buy these cookies at the farmer's market, these great home-baked cookies, the ones he eats are always gone like within 36 hours, and that'll be like 3 bags of 5 each. And I'm able to spread mine out. So I started thinking, it's kind of like that. So the synthesis is somebody's baking these cookies and making them. The storage is I bring them home. So the chemicals are stored in the brain, right, in the end of the brain there, or the nerve cell, I'm sorry. I bring the cookies home, I hide them, I store them in the cabinet. However, he always knows where they are, and he finds them, and they get set out on the counter. So the neurotransmitters are then released into the synaptic cleft, that little teeny weeny space between the nerve cells. So once they're out on the counter, it's Katie bar the door, and they bind to Roger's hand. And in the case of the neurotransmitters, there are other spots where they bind on neurons and transporters and all kinds of stuff that's way over my head. And then, then the action of that neurotransmitter is terminated when it hits that binding site and does its job, and that would be when there are no more cookies left. So I intentionally buy cookies that he doesn't like. So the bottom line sums it up. Drugs can alter synaptic transmission by any of these steps at these sites of communication between the nerve cells. There we go. So I just put this in there, not just because partly because I like it, and partly just to show that this kind of describes all of the different steps that we just talked about. It's terribly complex. And if any of you are interested in knowing more, I would suggest looking at some of the work of a psychiatrist named Stephen Stahl. He's a brilliant neuropsychiatrist, but he does these great animations of how all this transmission takes place. So these are enzymes making the neurotransmitters. Some of them are degraded in the cell, but some of them make it down here to the receptor site where they're picked up by this receptor site. That's all I have to say about that. So we're not going to go over this stuff. I just wanted to toss out some of the words that you'll run into when you're reading about pharmacology. Some of them you already know. An antagonist is working against something, an agonist is making it happen, some things are blocked, some things are taken back up, and on and on. One of the really important concepts is the CYP450 enzyme system, and that's that enzyme system that is really complex and it metabolizes drugs. And some drugs, some of the CYP450 enzymes encourage other drugs, and some of them block them and break them down. And then when you have polypharmacy happening, you have things happening between the drugs that you really don't want to happen, but it's a function of this CYP450. Have you guys ever seen that language? Cytochrome P450? No. Okay. Well, the only thing that I wanted to make sure that I said about that was that pharmacotherapy has gotten more and more complex with more and more drugs on the market, and some of them enhance others and some of them act against each other, and that's why it makes it really, really complicated. So I thought a good place to start would be with schizophrenia, because the symptoms are so flagrant and out there, and I just wanted to review kind of what the theory is of what's happening is to create the symptoms. So the dopamine in the limbic system, it's back here, they cause those positive symptoms of delusions and hallucinations. And the antipsychotic drugs, the typical antipsychotic drugs of old time, chlorpromazine or thorazine, Malril, Prolixin, those block the effect of dopamine. So they're going to help out with those things that you see, those positive symptoms or things that you see. The things that you don't see are the negative symptoms. You guys know that. And so some other drugs take care of that by liberating some dopamine in different brain areas. So we've got different ways to approach different symptom kind of clusters. So just as an example, and because you'll find this on here, and I just wanted to illustrate, so different antipsychotics can treat different drugs. So schizophrenia, schizoaffective, bipolar, so they can treat symptoms of those particular illnesses. They also have some off-label uses. So you'll see sometimes drugs used for something that it doesn't seem like it would make sense. For instance, and Joanne will remember this, remember what we used to give for intractable hiccups? You don't remember? Thorazine, yeah. So you got this big, powerful antipsychotic, and it treats hiccups. I just always found that kind of amusing. So there are some off-label uses in all pharmacology. There are off-label uses. So here are some of the pharmacological effects of the antipsychotic drugs. So in the hospital, when we're taking care of somebody that's incredibly agitated and psychotic and possibly harmful to other people, we're going to give them drugs that are going to cause some tranquilizing effects so that they can slow down. And that happens within an hour after the drug is ingested, quicker if it's an injection. So for the full antipsychotic effects, though, for you to start seeing reduction in those positive symptoms, the hallucinations, the delusions, that's going to take 6 to 8 weeks. Negative symptoms are harder to treat, and some of the second generation antipsychotics, which we'll talk more about that, they are more effective for the negative symptoms. In other words, the things that you would like to see that you're not seeing. How many remember Bleuler's 4 A's of schizophrenia? Joanne's nodding. It's only old nurses, I guess. So those 4 A's are affect, apathy, associative looseness, because they wanted it to be another A, and what I forget, ambivalence. But those were kind of a standard way back to think about how the symptoms of schizophrenia present themselves, and that was Dr. Bleuler's conception of it. But think about those as negative symptoms. So it's stuff that's missing. So when your person with schizophrenia comes in your office and they're just really flat, they're missing that, it's gone. So those are negative symptoms. It can also help with personal relationships in those ways. And then the affect, we mentioned that. And that, when you think about how our patients are perceived in public with that flat, absent, they really look crazy, is there anything in there kind of look. It's really important to try to help people with that so that they can enhance their interactional potential, I suppose, with others. I just wanted to emphasize one thing on this slide, and that is that cigarette smoking interacts a lot with that P450 metabolizing system. And so there are some drugs that if a person smokes while they're on this drug, the combination is going to cut down the effects of the drug, or vice versa. Smoking may increase based on what happens at that 450 level of metabolizing drugs. And that's really important because lots of our folks smoke. Yeah. Oh, I didn't say too, do you guys know the difference between pharmacokinetics and pharmacodynamics? Because that's an important concept when you're understanding how the drugs work and what they do. Pharmacokinetics is what your body does to the drug. How does it absorb it? How does it break it down? How does it eliminate it? And pharmacodynamics is what the drug does to your body. So is it addressing the target symptoms that you want it to address? So, as I mentioned, we had the first generation of antipsychotics that we treated our folks with schizophrenia and other psychotic disorders. And those were things like Thorazine, Stelazine, Maloril. You guys haven't heard of those old things, have you? Yeah. So, again, there's what they do. They do more partly because they have a tranquilizing effect, but they help the positive symptoms, the hallucinations, the delusions. They're less effective on those negative symptoms. In other words, they're less effective on the amotivation and the apathy and the flattening of the affect, etc. They're also cheaper, lots cheaper, and they went generic long time ago. I don't know why I have this down here on the bottom. I think I did the same thing twice, didn't I? I was cutting and pasting. Sorry about that. Okay. So this is simply a list of which drugs fall into which categories. Because we also have, aside from typical and atypical, we have high potency, moderate potency, and lower potency. And these are all of the first generation drugs, is how they kind of classify them. So high potency means you get a lot of bang for your buck. So 2 milligrams of Haldol, I think is equivalent to 100 of Thorazine. So that it's a more, I want to say concentrated effect of action in the high potency. So that's why you see the dosage differences. Whereas low potency, things like Thorazine, you have to give a bigger number of milligrams, a bigger tablet, it weighs more. It's 100 milligrams of the drug. So that's just an important concept to know in case you ever wonder, well, how come they're given so little? They're given 2 milligrams of Risperdal, but yet we're going to give this guy 100 of Thorazine. And kind of just as a rule of thumb, the high potency drugs, Haldol is probably the one you're most familiar with, and we also give a lot of Prolixin because we have injections. Those cause more of the extrapyramidal symptoms, the movement disorders, and prolactin elevation, and that's a problem because when men have elevated prolactin levels, they grow breasts, and that's, you all have seen that with our patients. Whereas the low potency, the Thorazine, the Mellaril, cause that particular bundle of symptoms, and really orthostatic hypotension, so that when people, if you have your patients on some Thorazine at a big dose, even a moderate dose, you want to be sure when they stand up they're careful so that their blood pressure has time to adjust. That's what orthostasis is. Is this making any sense?
Yeah.
Okay. Okay, so moving on. We just finished talking about kind of the traditional old drugs, and now we're moving on to the atypical antipsychotics. And I would also just say that just because that first group is old, they still work. And these are just these are second generation, because what happens with these drugs is you don't get as much tardive dyskinesia, you don't get as much extrapyramidal effects. The extrapyramidal system is a tract of nerves, nerve cells that run actually from your brain down to certain portions of the body. And those are the ones that give us movement. The extrapyramidal symptom is involved in movement. And people, for instance, with Parkinson's disease have disturbances in their extrapyramidal symptoms. So that's why you see our people have pill rolling. That pill rolling you see is the same pill rolling tremor of someone with Parkinson's disease. It's just that we caused it with this group of meds. So the really good thing that happened in 1990 was clozapine came out, and some of us were around then. Were we, Joanne? Yeah. Around in 1990? Yeah, we were. And clozapine was the first of the atypicals, and really has made a difference in kind of the overall treatment of people with these disorders. So they don't have that risk of tardive dyskinesia. Does everybody know what tardive dyskinesia is? It's those, yeah, okay, it's those intractable, can't get rid of them movements, tongue movements, facial movements, bodily movements. You guys have seen those. So they also, the other thing about this group of drugs is that they are more effective in treating the negative symptoms, and so they treat the positive symptoms, they treat hallucinations and delusions, but way more effective at the negative symptoms than the first generation drugs. So you do actually get some reduction in that kind of apathy, and people kind of wake up a little bit. And it's sort of like you're trading one thing for another. You have one set of side effects with one group of drugs, and then you have another set of side effects with another group of drugs. And kind of this is showing a little bit of the differences. So over here think Thorazine, Mellaril, Haldol, and then over here think Risperidone, Clozapine, and those groups of drugs, Abilify. So the traditional agents, higher risk for adverse effects, and again, they're cheaper. They have a lot of anticholinergic effects, and anticholinergic effects are the things that you see like dry mouth, like me right now. It's related to the fight or flight thing. But it's dry mouth, can't pee, anything that dries you up. Anti-adrenergic effects, and that has to do with your sympathetic nervous system, your fight or flight. That's why you get the drop in blood pressure sometimes with those drugs. And they are more sedating, and they do cause significant weight gain, and you all have seen that, and also extrapyramidal symptoms. Whereas the atypicals have a greater effect on negative symptoms than the traditional agents. They also cause weight gain. It's a huge problem. They cause lipid problems, diabetes. People can actually develop diabetes as a result of taking these drugs. Hypertension, but less extrapyramidal symptoms, so they don't have all that movement disorder that you see with the other drugs. And over time, we have come to notice in practice, at least we do it at the hospital, that some people respond absolutely beautifully to atypical agents, but I'm telling you and this is not scientific, this is just me observing, and anybody can speak up if they disagree. But there's sort of like a subset of people that it just seems like they gotta have the old stuff. I don't know, that's really anecdotal. So what can you expect antipsychotics to do is these things. I forgot that I had notes here. So they're gonna help with all of that, those symptom clusters. And again, we'll talk a little bit about side effects in light of how they can lead to rehospitalization. Because having seen some of the side effects in patients, and I know you have, from these drugs, they're not pleasant. They're really not pleasant. And so people don't take them. And in particular, those extrapyramidal side effects, the movement disorders, that's like, everybody can see that, and it's embarrassing, and people don't like it, and so they stop taking their meds, and then they relapse, and then they get into the rehospitalization. So the high potency, that would be Haldol. Antipsychotics would be the most likely cause of that. And so with the newer drugs, they're less likely to get those movement disorders. So, I don't know, I'm sure somebody's done some data, but the extrapyramidal symptoms the lack of them seems to have helped people stay out of the hospital because they keep taking them. We'll skip through this. This was just in there. I liked the fact that it helps you when you think about that brain, that piece of the brain, those nerve tracts. It helps just kind of understand the biology of the disorder and kind of take some of that stigma away. But I did want to mention this. At higher risk for extrapyramidal side effects, those movement disorders, are women, first episode schizophrenia, older adults especially, and then people who have more affective symptoms. I didn't know that till I was preparing for this, but tend to have higher risk. And here are the antipsychotic side effects. We've already talked about them. I did not know about this either. I'd never heard that. PISA, but you've seen people leaning, right? That's what that is. Dystonia, I would say a word about dystonia. That's a really kind of acute, can be very acute symptom where muscles get super duper hypertense. And that's a real problem, physiologically speaking. But I wanted to mention neuroleptic malignant syndrome because it is dangerous and actually can be lethal. Has anybody, besides Joanne and me and probably Deb, seen NMS? No. It is just a really over-stimulation of the whole system, and people, I think I thought I had a slide on here about that. Maybe I don't. But temperature goes sky high, all the vital signs are elevated, people are sweating like crazy, they become delirious, and it really is life-threatening. You have to give emergent drugs fairly quickly.
Kathy, would Stephen Johnson's be one to discuss as well?
When we get to
Oh, okay.
lamotrigine, I don't know a whole lot about Stevens-Johnson's. I know what it is. Yeah.
Okay.
Also life-threatening. Yeah. So again, just another breakdown on the antipsychotic side effects. So one of the things that I always found to be a challenge when I was working acutely, and sometimes even now, is this issue of akathisia, which is that restlessness. And sometimes it's really hard to differentiate between akathisia and just psychomotor agitation, because I'm agitated. And so I would just point that out from this slide. It is the most common extrapyramidal symptom, and it's uncomfortable for people because they can't sit still, and they can't quit tapping their feet or kicking their leg or doing whatever. And it's, you know, people are kind of embarrassed by that sometimes. But it's tough to treat. So I just wanted to say a word about anticholinergic side effects, because we've mentioned that a lot. Remember I said that was one of the main neurotransmitter systems, acetylcholine, in the body. And drugs that want to shut down the anticholinergic, or shut down the cholinergic symptoms are called anticholinergics. That's cogentin, artane. There are some other drugs you can use for that, for those motor side effects. But this is, I like this little thing. It's just encapsulates what you see with delirium, and it's true. So anticholinergic drugs are well known to cause delirium, especially in older people. That's why we talked the other time about delirium and people taking excessive amounts of Benadryl become delirious, same thing. Okay, so we can give cogentin, we can give artane, and if you read through that and if you put your pages side by side, you'll see that some of the anticholinergic agents have the same side effects that you're trying to treat. So there's a little bit of a challenge. More anticholinergic side effects. People quit peeing. We've seen that a lot. People with anticholinergic drugs have trouble emptying their bladder sometimes, and then they get in big trouble with that. So there's these other symptoms, or other treatments for extrapyramidal symptoms. On occasion we've used Benadryl and some of these others. There's that new drug out, Ingrezza, and I really don't know much about it. Do you guys have anybody out of Westlake on Ingrezza? Has anybody in here had any clients come in and have taken Ingrezza? Not seen it. Oh, here's neuroleptic malignant syndrome. So, life-threatening kidney failure. People go into kidney failure because there's so much muscle breakdown, it's clogging up the kidneys. There's clozapine. There's one of the, clozapine is one that smoking decreases the level of drug. Okay, so switching, we're leaving antipsychotic drugs, and this is, central nervous system stimulants are not, I don't have great expertise in those. Y'all use them with kids, you know, and sometimes with adults as well, but they enhance the excitatory capacity of the neuron. Limited clinical applications, although you do see it a lot with kids. Is anybody in here children's center person? Yeah, so you do see it, right? A lot, yeah. Oops. Okay. And those are the drug classes that are used. Interestingly, I saw a lady yesterday, and she has this sort of ADHD by history kind of thing. And I'm really struggling to decide if I think this is all ADHD or if she's manic. And so, well, you know how that comes out. All right, anti-manic drugs. Probably if you ask anybody, most anybody, who's worked in an acute care setting, their favorite patients are going to be people with bipolar disorder, right, Joanne? Yeah, mine were anyway. So what you want to do is, if they're manic, bring them down, and you want to stabilize their mood so they can actually function. So lithium is a salt. It's an ion. It's not really even a drug. And there are some implications to that which we'll get into, but it can be a really serious overdose. People die. Lethal overdoses can affect kidney function. Has anybody had besides many patients who've landed on dialysis as a result of long-term lithium therapy. It happens because it just wears our kidneys out. Because lithium is one of the few drugs that is excreted solely by the kidney. It doesn't undergo that metabolism in the liver. It's just used and sent out the kidneys, and it takes a lot of effort on the part of the kidneys. And you all have heard of lithium levels, so you watch the person's lithium level regularly and carefully. Some people can maintain a higher level without side effects. Some people can't. So very common side effects: nausea, dry mouth, diarrhea. The thing about side effects of lithium is those are also indications that somebody's level is high, that they might be toxic. So you really have to differentiate. The tremor is really common, very common. And more common side effects: they pee a lot, they drink a lot. 70% of patients, I was surprised it wasn't higher. All of those things. So lithium, again, overdose is very serious. These are some symptoms of them. And we've seen a few over the years. That's why you really just have to assess people very, very carefully when they're on lithium, because it's such a terrible overdose. So if someone is acutely toxic, their level has elevated for whatever reason, those are the symptoms that you would see: seizures, oliguria, really just peeing a lot, circulatory failure, coma, and death. And I don't want you to worry about this, but the reason that I put this in here is to illustrate how closely you have to work with people who are taking lithium in terms of education, because lithium's a salt. So what is your body wants a normal level of sodium, right, of salt. Just think salt. So if a person on lithium is eating more salt than usual, or a lot of salt, they're going to excrete the lithium, right? So their level's going to drop. And vice versa. So what we really did as nurses was educate patients about dietary interventions, like just use salt, but you just got to use kind of the same level all the time. Otherwise, your body doesn't know whether it's a lithium salt or a sodium chloride in your table salt that it wants to hold on to or get rid of. So again, and then this is really, really important. If you lose a lot of sodium, if you're taking lithium and you lose a lot of sodium because you've been outside exercising, and you're losing that sodium, your level of lithium is going to escalate because you're dehydrated, one, but also because when you're dehydrated, your sodium level is higher. See how complex it is? It's fascinating. Okay, this was just a list for you to have of, these are the atypicals. You're all familiar with all those names? Okay. Some are more sedating than others. Anticonvulsants are used also in treatment of mania. We're still on the mania piece. And you all have seen that, right? You've seen people come in on Depakote. So the idea is it just dampens that threshold for activity. That is the Kathy Lee short version of it. It's really complex. So moving on to antidepressants. Antidepressants treat depression. They treat anxiety disorders. Your goals are to restore a normal mood, and you really do want to get people to a normal mood, not just decrease their other symptoms, but restore them to their premorbid mood level. And also you will see people with bipolar disorder who may be taking antidepressants as well if they tend to have depressive symptoms during their episodes. It's not all that common. What we see more commonly are the use of a mood stabilizer and or one of the antipsychotic drugs, atypicals, that has mood stabilization properties. I did not know this. Most common prescription is antidepressants. And I did not know that it's more commonly prescribed in the white population until I looked through this. Isn't it fascinating that 50% of people with an antidepressant take more than one type? been seeing that. But so just a biochemical theory of depression, again, transmitters involved, and it has to do with that little cleft between the nerve cells and what's happening in between them and transmitting the neurotransmitters that should be. So in talking about depression, you'll mostly see serotonin, norepinephrine, and dopamine as targets. We're going to skip that bottom little bit there. That's really just telling you how it happens, that there could be dysregulation between what's happening on the receptors on the two nerve cells, or genetic output. Nerves die, so they don't produce what they're supposed to. They don't produce synapses. So, in this day and age, first-line treatment is usually SSRIs, serotonin reuptake inhibitors, so it's trying to keep more serotonin available in the synaptic cleft. And tricyclics, which back in the day was what we had, and even back in the day before that were the monoamine oxidase inhibitors. All drugs work, all these drugs work. It's just kind of weighing the balance of side effects, tolerability, and what your most troubling target symptoms are. Is anybody familiar with the MAOIs? The people that have to be on low tyramine diets and, you know, okay. Don't see them as much used to, they're really effective. Tricyclics are the drugs like amitriptyline, Eldo, nortriptyline, very helpful. You see them used a lot more now for sleep, small doses. So that's a listing of all of the different combos of what happens in the reuptake inhibitors. So SSRIs are drugs like Paxil, Prozac, Zoloft. Then there's the venlafaxine group. Those are reuptake inhibitors for serotonin and norepinephrine. So it's not just acting on one system, serotonin, it's acting on norepinephrine as well. The NDRIs, bupropion has its role. And then the newer antidepressants, mirtazapine and vilazodone, I think is Vibrade. I haven't seen anybody on. Do you have anybody on Vibrade? You do, Amy?
Used to.
Used to. Does it work?
She doesn't come here anymore.
Oh.
Yeah.
Did it work? I don't see it. I'm sure it's not covered by payers. Okay, so antidepressant use. So serotonin syndrome is sort of kind of like NMS, neuroleptic malignant syndrome, except just in general it's less severe, but it is a kind of hyperexcitability state. Antidepressant apathy syndrome, where their mood starts to increase, but it just kind of gets stuck there at a level of apathy. Withdrawal syndrome, so sometimes people have a resurgence of symptoms when antidepressants are removed. And some of them, seriously, they call it poop out. I'm not making that up. But sometimes they just seem to quit. And I know I have seen that in people. I don't know if you all have, but the same drug that's been working well for you for the past 5 years suddenly just quits. So you got to look for something else, maybe in a different class. And then, of course, sometimes people suicide when they start antidepressants, and I'm sure there are lots of different theories about how and why that happens, but it is a true phenomenon. With the SSRIs, commonly you get gastrointestinal symptoms. The anticholinergic effects, such as dry mouth, sedation, and sweating, that happens. It happens more often in tricyclics, but it happens. So those are some central nervous system, and those are the ones when you get serotonin syndrome. Those are the ones that are exacerbated. And I have seen this actually happen, sodium depletion in older people on SRIs. I think we had once or twice that happened in the hospital. Sexual dysfunction is very common, and I'm sure you hear about this from your clients, about 50% of patients. So all in all, the side effects, the profile is less sort of alarming, I guess, than it is with some of the other categories. No, I've got a lot of repeat here. Okay, so MAOIs, monoamine oxidase inhibitors, Nardil is probably the main one you would see, Parnate. Anybody besides Joanne? We're really old, Joanne.
I'm getting older by the minute, actually.
They do work. They do work, and there are people still taking them, but this is the drug class that you have to be on the low tyramine diet. Have you ever had your clients tell you that? Yeah, okay. So I just put this up here because I thought it was interesting because we don't ever talk about it anymore. So if you look at this top category, I'm sorry, this is just a really bad joke. And this is Dave Foley, as in fact on me. But in this category, who would not be able to take MAOIs? Yes, two of you.
Hannibal.
You got it! Way to go, Jane. Hannibal Lecter. Right? He ate his liver with some fava beans. I don't know why that struck me in. That's very Dave Foley-ish. Thank you. Is that what you were going to say, Carol? Yeah. All right, we already talked about that, but the point of this one is that if you're taking other agents that have serotonergic properties, then you're also more at risk for serotonin syndrome. So tryptophan, people buy over-the-counter supplements. This stuff, bad. Bad. Okay, we're gonna skip past that one, maybe. Here we go. Drug interactions, again, with every group of drugs that we give, you're going to have interactions. Sedative hypnotic drugs given people to sleep. Barbiturates in the old days, right? Again, Joanne, it's you and me. But the barbiturates were given, but we have a little bit better choice now. So we have benzodiazepines, lorazepam, alprazolam, probably the two you see most often. And then some other benzodiazepine-like drugs like the Lunesta and that group. So that's just really to help people sleep, hopefully used in the short run. They can be abused. But of course the benzos are used for anxiety as well. Those are just some of the other uses. We'll go past this one. I like that little piece at the bottom, therapeutic uses for benzodiazepines. One of the things in acute care that you see is treatment of alcohol withdrawal, particularly with lorazepam because of its, the way that it's metabolized. Those are adverse effects. That anterograde amnesia is a for sure thing. That's why they give it to you before you go in for a procedure. You go in for an EGD and they give you whatever they give you. So you don't want to remember what happened when you had a tube stuck down your throat, right? So of course the issue of abuse. Oh, that sleep driving thing is pretty interesting. Have you guys heard about it's part of that amnestic kind of thing. I always find that interesting. You can't have tolerance, you can't have physical dependence, so if you're taking lorazepam routinely, you can't just stop it unless it was for a very brief period of time and then you need to taper it, because you will have seizures. They can be really bad overdoses. Generally, the ones that I've seen in the hospital setting were not. They were usually if they're in combination with something else, of course, that makes them really more dangerous. These are some of those other drugs that are used for sleep. I don't know, Roserum. I don't know anybody that's taken that one. You guys have anybody taken that one? That's Roserum. Barbiturates, you guys know about barbiturates. Also, you will see trazodone used for sleep. I'm sure you guys have clients in your caseload that are using trazodone. It's real helpful in small doses for sleep, 25, 50 milligrams, or a little bit more sometimes. And also doxepin, and also doxepin's an old tricyclic. It's a really potent one, so you get a lot of bang for your buck, so it's usually given in smaller doses. More often you'll see amitriptyline and nortriptyline. And then sometimes people are instructed to take Benadryl over the counter for sleep or Visceral. And those, it's not that they're not sleep-inducing drugs, that's a side effect. You're taking them because you want to get that side effect. And that is that. Let me see if there were any other stories. Stevens-Johnson, and I'm not a great expert on that. I do know that it is a potential life-threatening side effect of lamotrigine. So for myself, whenever I would have a patient, or when I've only had, I think, like one, I've really looked at it really carefully, talked to the physicians, but my recollection is this rash thing that goes from rash into like a systemic internal rash, not just a rash on your skin. Have you had experience with it, Amber? Or?
Yeah, I wouldn't. I worked on a psych med unit for a while, and we would see it not just with lamotrigine, like sometimes it would be with other meds too, even just like medical meds, if someone has a really nasty response. But yeah, just if anyone is starting a new med and they break out into a rash, they need to call their doctor as soon as possible.
Absolutely.
To rule it out.
Yeah.
Because then the rash can develop down your throat before it even happens on your skin.
It is life-threatening for sure. Yeah.
Thanks.
So, yeah. What other questions or comments or? Yes, ma'am.
How do you address clients who, for one reason or another, because of side effects, don't want to take medication? So an example would be a young woman who is really upset about the weight gain that she's had. And it's just like, I don't care, I'm not taking this anymore. I cannot balloon up another 20 pounds.
Yes.
How do you?
It's a real problem. And, you know, none of us wants to be uncomfortable, and none of us wants to gain weight. And, you know, there are a lot of choices for meds, and so, I mean, I would think that a prudent clinician would try to look for something that would achieve relief of that person's symptom profile, but not have necessarily the same side effects. I mean, and you do all the teaching and all of that stuff with exercise and diet and such, but I would look for another agent. I mean, sometimes there isn't, but most of the time there's something else you could do. I would not prescribe amphetamines.
Yeah.
Joanne, do you have any other tidbits from the past that you want to
I
share?
was just thinking about the weight gain, which is always a big problem. And like all of us, once you're over being sick, you forgot how terrible it is. And so if you can kind of like maybe revisit some progress notes of how they felt when they were sick. And, you know, it's the lesser of two evils sometimes.
Yeah, that's hard. Because we've all known people who really struggled with that weight gain. You know who I'm thinking? A gentleman that is now dead, but started out looking like Michael Jordan and ended up he was so huge. And that was so hard on him, on his self-esteem. That was my favorite ever patient. One of my top three. My top three are always people with mania. What else? Is this anywhere what you guys were looking for? I wasn't really sure how much chemistry you wanted. I hoped you didn't want a whole lot. Yes.
Can you talk a little bit about the effects of combining alcohol with these meds and how we can address that with a client?
Yeah. Well, there would be a couple of, you would want to think about if the drug has some CNS depressant effects. Of course, alcohol is only going to exacerbate that. That's why alcohol and barbiturates are very bad overdoses, because they just shut it down. So you have to think about it at that level. And it gets to be hard just as a person who's new to prescribing. it's hard to tell if somebody's drinking and taking meds. It's hard to tell what's doing what sometimes. And so, do they need more antidepressant, or do they just need to not drink because alcohol is what? A depressant. So that's a challenge as well, and I've talked with people about that too, that it's really hard for me to tell what to do with your medicine if you're drinking or smoking pot or, you know, whatever else, because I don't know what's doing what. I think those would be two of the bigger issues. There's the physical safety, but then there's also the, how am I going to know what to do? It's a challenge, and the comorbidity is so high. Anybody have any other suggestions for that question? It's a good one.
I would sometimes talk to patients about there only being so much space in their brain for chemicals, because if they're drinking or using other substances, it's going to decrease the effectiveness of the antidepressant.
Yeah. So much space in the brain. You know, as we get older and our brain shrinks, we got a little more space between. Let that go. Anything else? If you get back to your desk and you look at the slides, and again, I apologize that I didn't take out everything that I thought about taking out because I figured this is going to come up again, and I wanted this to be multi-purpose. So if you get back to your desk and you have a question, don't hesitate to email me. And I hope that this is helpful. I had fun doing this, actually, because it's like, whoa, look at the same drug is in 3 different categories of use, so. I wish we could get as much attention focused on research and funding for what our folks need. But that's another topic.
Yes.
I get really enraged, so I don't know. I don't want to go there.
Thank you very much, Kathy.
Thank you.
Sure.